Good morning, everyone. Welcome to an Evoke Neuroscience Lunch and Learn webinar. My name is Dr. Morgan Evenson. I'm the Director of Medical Affairs here at Evoke. And before we dive in on our content today about recognizing depression, I want to make sure that everyone can hear me and that you can see my screen. So I want you to locate the GoToWebinar menu and find the question section and type in there, let me know that you can hear me loud and clear. And keep in mind that you can use this question box as we work through the content today. Let me know if anything pops up and we can cover it in lifetime. Otherwise, I can always reach out to you after the webinar. And awesome, it looks like everyone can hear me. So while you're in that GoToWebinar menu, you can also check out the handouts section. I've uploaded a PDF of today's presentation, so you're welcome to take notes or save that and reference it later, as there's a great resource for you. So diving in today on recognizing depression, perhaps appropriate given the year that we've had in 2020, and certainly as we really dive into the winter season, oftentimes we'll be seeing patients with cases of seasonal depression, and holidays tend to be a challenging time, kind of regardless of the weather, the season, for a lot of folks. So very pertinent subject matter today on depression. And the learning objectives are really going to be reviewing the biomarkers that you can gather from the Evox test in order to recognize this disorder. So the first is really going to be talking about heart rate variability and understanding the difference between time and frequency domains. And I want you to be able to identify what types of changes within heart rate variability are associated with depression. We're going to be talking about event-related potentials and understanding how changes in latency and power within these ERPs can be associated with depression. And finally, I want you to be able to interpret database comparisons of the EEG head maps in order to recognize changes related to depression. I think oftentimes interpreting head maps is the most challenging component of interpreting these Evox reports. So we'll spend extra time on that head map section to make sure it's really clear. The good news is when it comes to depression, oftentimes it's a very clear pattern that we're looking for. So we'll review that in detail as well as some case studies. Now, the reason why we're talking about diagnosing depression in the first place is that it's a very common disorder. It affects up maybe even more than 18% of the worldwide population at least once on one occasion before age 40. So we're talking about our younger patients here. It's not extremely elderly patients all the time, especially for adults kind of in the throes of stressful careers. We can see depression kind of go hand in hand with a lot of middle-aged life events. We know that depression is going to affect a lot of different cognitive domains. So it's not just mood and affect, it's perception, personality, and higher processing functions as well, like memory and language. So short-term memory loss can be something that we see. Maybe somebody's coming in with cognitive concerns, and they often will link memory problems with the fear of dementia, but in fact, it can be depression. Now, a problem with diagnosing depression as the current approach stands is existing classification systems are really based on the subjective description of symptoms, but symptoms can mirror those of other disorders. So there was a great study looking at non-nursing home adults, and they had memory problems due to a lot of different disorders. So when you're relying on the patient to just say, yes, I'm experiencing this symptom, well, we know it's not specific just to depression. It can be other things as well. And so the challenge is relying on just those questionnaires in order to make a diagnosis. Now, that's not to say that questionnaires aren't extremely helpful, and they certainly are, and that's why we've included them in the Evox software. So there's a component of our software called SimpCheck, and it's really Evox for mental health. Within this software, there's a questionnaire called PHQ-9, and it's really specifically designed to detect depression. So it's basically the gold standard measurement tool for major depressive disorder. And it's giving you a common language for screening and tracking depression. Not everybody has an Evox system in their practice. So this is a great common language to talk to other physicians about your patient's current state. It's really short, only 9 questions, and it's got pretty good sensitivity and specificity for major depression. We recommend using it to help screen for symptoms, track symptom improvement, and also to set treatment goals. So in terms of who to screen, really the recommendation is all adults at least every 5 years, which can be surprising. So even if somebody doesn't have a history of depression, isn't complaining of mood and affect changes, we still want to make sure that we're checking them out at least every 5 years. And this quick screener is an easy way to do that. Of course, for higher risk groups, those that have a family history or a personal history of mental health disorders, we want to be screening them more regularly. And the good news is this is an easy and quick tool to do that. For our Evox assessment, when you perform this screener, we score it for you. It's really easy. So anytime there's 5 or more answers to the right of the red line on this chart, we want you to consider major depressive disorder and really use the total score in order to kind of determine the severity of the disorder for this patient. Now, that being said, this screener still is 100% reliant on the patient answering how frequently they experience symptoms over the past 2 weeks. So really the next step and kind of a higher level of care is to look at the brain itself. We know without any uncertainty that depression is linked to the brain, right? It starts in the brain and it affects us behaviorally, but it's changes in the brain that is causing this disorder. So of course we want to look to the brain, the organ in question itself, for biomarkers that are correlated with depression. And within your Evox report, there's really 3 main categories that are relevant. The first is heart rate variability, specifically a reduction in heart rate variability. The second is event-related potentials, looking at both P300A and P300B. And finally, our resting state head maps, specifically looking for low alpha power within the frontal region of the brain. So diving into these 3 components, first up, we've got ECG, looking at heart rate variability. So we know that there's synchronized electrical activity between the brain and the body. And this really is what underlies our ability to perceive, feel, focus, and perform at our best. Now, the reason why we look at ECG for the Evox assessment, which is a neurological assessment, is because ECG gives us insight into the autonomic nervous system. So looking at if somebody is kind of sympathetically dominant, meaning they tend to be stuck in fight or flight mode, or if they're parasympathetically dominant, meaning they're stuck in rest and digest mode, or if they're perfectly balanced and can easily shift between these 2 zones, depending on what is required in the moment and from their environment. And that's what we would like to see. Unfortunately, that's not always the case, but understanding sympathetic or parasympathetic dominance really does help us know how the autonomic nervous system is playing into a possible disorder. So heart rate variability is our window into this autonomic nervous system. It's a measure of neurocardiac function that reflects this heart-brain interface and the autonomic nervous system dynamics. So there's 2 different ways to consider heart rate variability. The first is the time domain. It's really the most intuitive one if we're talking about variability that naturally leads us to think about time. So the simplest way to phrase this is how much variability is there in heartbeat to beat intervals. Now, it's worth noting that the heart is not a metronome, contrary to what your patients might believe. We actually don't want the heart to beat like a metronome. We want it to beat rather erratically, meaning the heart can respond in real time to what the body needs. So when we look at the time domain metric of heart rate variability, we can measure the differences between end-to-end intervals in milliseconds and just ask how variable is the heart beating. Now, as we said, a healthy nervous system is going to respond in real time to what the body needs. So an ideal heart rate variability is high, meaning there's lots of variability, as opposed to low, meaning the heart is beating like a metronome. When we see a high heart rate variability, it's indicative of really good overall heart health, low stress levels, and strong autonomic resilience. Of course, there is an upper end to this. We don't want to see heart rate variability that's too high, but the tendency is to see the heart rate variability that's too low, meaning we are concerned about heart health. This is a great metric overall for predicting myocardial infarct risk. So we certainly want this biomarker to be healthy in all patients, and we want to keep an eye out for it for our depressed patients as well, as we'll talk about in a couple slides. So that's our time domain. The next domain is a frequency domain. And this question is really, what are the underlying rhythms in heart-beat-to-beat intervals? So just like the brain, the heart beats in different rhythms that can be graphed according to frequency. So here in this chart, on the top line outlined in blue, that would be our original frequency graph of heart rate. And we're able to filter this out into different frequency types. So very low frequency, and then high frequency. And the question we're asking is, how much power does each underlying rhythm have? Now, power, think of that as reflecting the strength of vagal activity. And ideally, we want to see the most power in our low frequency zone. The reason why is these different frequencies relate to different autonomic processes. So very low frequency relates to sympathetic dominance, high frequency relates to parasympathetic, and then low frequency is kind of a balance between the two, meaning that the autonomic nervous system is really resilient and can deal with stress well and rebound well. So that's where we want to see, and that's where we want to see the most power lie. In the Evox reports, we've made it really easy for you, a simple bar graph showing how much power is in each of these three zones. So ideally, your patients are all going to look like this. They're going to be balanced right in the middle. Most of their power is going to be in that low frequency zone. However, that's not always the case. And when it comes to depression, a lot of studies have shown that heart rate variability changes with this disorder. So looking first at the time domain, here we're talking about the variability between each heartbeat. Studies have found that patients with major depression have less variability than healthy controls, meaning their heart beats more like a metronome, they are less resilient. And this happens actually to the point and to the extent of cardiac neuropathy. So when you compare major depression to patients that have had a heart transplant, there's no difference, but they do differ from the healthy controls. So it can be quite a very pointed biomarker that comes up as abnormal for our depression patients. When we talk about the frequency domain, studies have shown that there's a reduction in the high frequency power. So meaning there's a shift towards sympathetic dominance. Recall that high frequency relates to parasympathetic, very low frequency relates to sympathetic. So we don't have enough of the high end, we're going to shift towards that sympathetic dominance. And a lot of studies have shown when you see depression patients, they tend to be sympathetically dominant as a reduction in that, as a result of the reduction in high frequency power. So it's really important to consider heart rate variability when you're looking at any patient, and certainly when you're considering a diagnosis of major depressive disorder. Now, I want to note that antidepressants really don't affect heart rate variability. They're neither going to increase it nor decrease it, so that's great. The exception being tricyclic antidepressants. these types of antidepressants will block parasympathetic innervation. And what that means is heart rate variability is diminished. So if you're prescribing a tricyclic antidepressant or somebody comes into your office already on a medication within that category, keep in mind they're probably going to have a diminished heart rate variability. And worth noting as well that individuals with more severe depression are likely to have lower heart rate variability than those with less severe depression. So this is kind of graded based on the extent of depression. Severe versus mild, we can see more severe versus less severe changes in heart rate variability. So talking about how this is presented in the Evox report, we're looking for depression patients that can show possibly a reduction in SDNN. Remember, that's our standard deviation of end-to-end intervals, so our time domain. We're going to keep an eye out for reduced total power, meaning the combination across all of our frequency bands, just is there less total power? And then we're going to look and see if there's an unbalanced heart rate variability frequency spectrum. So we would expect to see a lot of this sympathetic dominance on the left side of the screen, meaning lots of power in that sympathetic band. But we can also sometimes see what's called a stressed pattern, meaning sympathetic and parasympathetic have a lot of power each, but the balance zone has hardly any power. So it's kind of a U shape. And this is really essentially the worst case scenario. You have a patient that is really stressed and tired and fatigued, and they're just tired of being tired. So keeping an eye out for both of these patterns. Of course, heart rate variability is not specific to any one disease state, so oftentimes we'll see different disorders layering on top of each other and manifesting in different ways for heart rate variability, but always wanting to keep an eye out and keeping in mind that depression certainly plays into this, this equation. So next up, we have event-related potentials. So ERPs reflect brain processing speed, and really it's time-locked neural activity that's related to sensory and cognitive processes. So breaking that statement down, essentially what we're doing is looking at a raw EEG signal and then noting every time a patient saw or experienced some type of stimulus. We're going to look at the window of activity right after that stimulus occurred, and then average all of these windows together in order to create your ERP, which is your time-locked EEG segment. So this ERP waveform is associated with attention, working memory, and executive function, specifically when you're looking at the P300 component. There are a couple different components within your ERP waveform. We really pay close attention to P300 because it does relate to kind of cognitive function. There's two different types of P3 ERPs. P3A refers to attention, and really not sustained attention, but attentional capacity. So I always think of P3A as an orienting response. If something changes in your environment, can you orient to it and pay attention to it? Certainly a very important component of memory, right? If you can't attend to something, you're not going to be able to remember it. And then P3B is our working memory component or our information processing component. And this reflects our sustained attention and the ability of the brain to combine resources to accomplish an action. So not only are you using P3A in memory of attending to something new in your environment, you're also using P3B, your working memory, in order to hang on to that information, process it, and then execute on it. So when we interpret ERPs, we're looking at two different factors for both P3A and P3B. The first is latency, and this is reflected on the x-axis. So on this graph, we've got latency, and it's measured in milliseconds, and it's literally reflecting how long it took the brain to mentally classify a stimulus. So in this example, we've got a control subject in our blue line, a patient with dementia in the orange line, and you can see there's a delayed latency in these peaks, from our control to our demented patient. On the y-axis, we're looking at something called amplitude. Amplitude reflects how many neurons are successfully working together in order to classify that stimulus. So I like to think of amplitude as mental horsepower. You want a lot of horsepower to be able to get up and go and process information efficiently. Now, looking at the difference between these peaks according to the y-axis, you can see that our demented patient has a severely reduced amplitude, meaning they don't have nearly as much neural horsepower. So, talking about depression and ERPs, a lot of studies have shown that there's a difference between healthy controls and patients with major depression. In this example, we're looking at P300 latency, so this is a stimulus, and you can see that depression patients took a lot in order to classify stimuli. So their brain is sluggish, it's not as quick to press on the gas pedal in order to process information in front of them. And interestingly, just like heart rate variability, this is correlated. So patients with very severe depression have extremely delayed latency versus patients with only mild depression which only have a slightly delayed latency. So this can be kind of a good biomarker to look at to kind of monitor treatment progression. It's quite a sensitive biomarker, which is great. And we anticipate that it will recover in parallel with kind of symptom resolution and backing out of more severe stages into mild stages and ultimately, hopefully, getting back to kind of a controlled, balanced state. And we can see the same trend when we talk about P300 power as well. So now talking about neural horsepower, we see a lot less amplitude compared to our healthy controls for the depression patients. So it's both P300A and P300B, latency and amplitude that can be affected by depression. And it does make sense, right? We talked about at the beginning of our webinar how depression can manifest with short-term memory loss. This is exactly why, because our brain isn't processing information quickly or effectively, and that, of course, affects short-term memory. So when we talk about ERPs and the report, in your comprehensive report, you can take a look at the exact waveform that we measured. What you're looking for is a peak within the green bar and really high on the y-axis. So breaking that down once again, we've got speed on the x-axis, so we have our ideal speed range that we highlight in green. We want to see the peak within that green bar. In this example, it's slightly delayed. It's to the right of that green zone. And we also want to see it really high on the y-axis, our amplitude or our power axis. In this case, it is high, it's about 20, so that's a great amplitude, really great horsepower, but a slightly delayed latency. Now, sometimes you'll see a result that's called indiscernible. And if you're looking at the summary report most often, all you're going to see is the word indiscernible. You won't actually see this graph. So it's helpful that when you do see that, to pop over to your comprehensive report and take a look at why the ERP was indiscernible. There's two causes for this within our report. One is that the ERP was too slow to be detective, meaning there was a peak, but it was all the way out at about 900 milliseconds, which just isn't where a P300 should be occurring. So our algorithm didn't classify that as a P300 peak. The more common thing is that there just wasn't enough power for the ERP to be detected. There just wasn't enough of a peak at all present in order for our algorithm to detect it and classify it as an ERP. So in this example, we have an indiscernible result because it's basically just noise. There's not enough neural horsepower to even get up and go and generate a peak when the patient saw stimuli of interest. So that's our ERPs for depression. We're keeping out for both latency and amplitude for P3A and P3B. And our third biomarker of interest is, of course, our resting state EEG or our head maps. So when we talk about EEG, we know it's because neurons communicate via action potentials, which are created by the exchange between sodium and potassium into and out of the cells. And this is a wave of ions that ultimately can reach electrodes that are placed on the scalp, which are then going to push and pull electrons, pardon me, on the metal surfaces of the electrodes. And so this push-pull difference is measured as voltage across time. We're basically measuring the spontaneous electrical activity of the brain in real time when we do an EEG. And we can report on this information through a frequency spectrum, which is shown here on the right. So on the x-axis, we have frequency, which is the number of cycles per second of the brain's spontaneous electrical activity. So we've got slow waves down at 0, all the way through fast waves at 30. So each of these numbers would represent a specific brain wave. And then on the y-axis, we have amplitude, which is the voltage present in each frequency. So all frequencies are generated in the brain at all times. As you can see, according to this chart, there isn't 0 amplitude for any single frequency number. But the power or the amplitude of each frequency does change based on the patient's physiological state and based on pathology. So we like to break down frequency into frequency bands, the slowest of which is called delta. And delta relates to slow physiological states. So think deep sleep. And when you fall asleep and get into deep sleep, you're going to be spontaneously producing more delta than you are right now. Theta is a little bit faster, but still considered a slow brain wave. And this is kind of relating to a drowsy physiological state. So when you're daydreaming, your mind is disengaged and often la-la land, you're producing more theta than if you were really concentrated and honed in on a task. Alpha is sort of our baseline mode. We're producing mostly alpha most of the time. So it's kind of just associated with being at a calm resting state. And finally, beta is our fast brainwave frequency band. So when we are engaged in a task, we're going to produce more beta than we would if we were just resting. So yes, these frequency bands relate to physiological states, but for the Evox assessment, we have your patient in a calm resting mode, so we understand the state that they should be in. So when we see differences between your patient and a standardized database, we know that the difference is really derived from pathology. And that leads us to our database comparison of why we're doing this. We want to know, how is your patient's brain functioning compared to healthy controls? And we color code this using a rainbow color map that represents z-scores, meaning how many standard deviations away from normal your patient's brain is. So when you see blue on these head maps, it means there's a deficit of that particular brainwave in that particular brain region. When you see red, it means there's an excess of that brainwave. So remember, your patient is sitting calmly, relaxed, first with eyes open and then with eyes closed. So we know the power that should be occurring within each individual head or brainwave. And so when there's a deviance from that normal, we're going to color code it as a deficit or an excess. And that relates to our disease pathology. So when you interpret head maps, you always want to ask first, what frequency are you looking at? Is it a slow frequency or a fast frequency? And that's because it really does relate to disease pathology. Today, we're talking about depression. That's a mood disorder, and mood things tend to show up in alpha. So we're talking about 8 to 12, specifically for depression, as we'll talk about. It's really like 8 to 10 where depression shows up. In terms of power, you always want to know, do I see red or blue? Meaning, do I have an excess or a deficit of power? Ideally, we'd like to see green in all frequencies. Most often we see a deviance of blue or red, and that means we either have too much of a certain brainwave or not enough of a certain brainwave. And finally, we want to ask about what brain region is the abnormality occurring in. And oftentimes, relating this back to the brain region will help explain symptoms that the patient is experiencing. So for example, when there's a abnormality in the frontal lobe, patients will probably be experiencing emotional or behavioral control problems because that's what the frontal lobe is responsible for. All right, so diving into our head maps and depression, something that has been really well studied is frontal hypoactivation, specifically within the alpha band, that is seen in depression. So something called alpha asymmetry can be displayed as low power in the left frontal lobe within the alpha band, so specifically within that 8 to 12 hertz band. And we call this frontal lobe hypoactivation, meaning there's just not enough activity for the front of the brain in that particular frequency band. Now, this pattern has been linked to depression. Notably, not all types of depression demonstrate asymmetry. So really, what I like to look for is just a general blue blob in the front of the brain in this kind of 8, 9, 10 head. So as shown here, this is a really clear case of depression. You see not enough activity, so blue, in the front of the brain for your alpha band, specifically that 8 and 9 hertz heads has it really pronounced. So this is a great example of the pattern you're looking for in depression patients. Sometimes you're going to see an asymmetry in this blue blob, as it kind of is now, but that kind of gets into a little bit of subjectivity in terms of if it's asymmetrical or not. So what I recommend looking for is just a deficit anywhere in the front of the head for this particular frequency band. So when you get your report, you, of course, are keeping in mind this is something that affects the frontal lobe. The frontal lobe is responsible for emotional and behavioral control, personality, attention, social skills, planning and organizing, and we're really looking in that alpha band. Remember, alpha is where mood tends to come into the equation, and oftentimes we're going to see depression manifest just as this is shown. All right, so a quick summary of depression biomarkers. We've talked about ECG, heart rate variability, time and frequency domains. So we're keeping an eye out for a reduction in HRV, specifically for SDNN, our time domain, and reduced high frequency power, which is our frequency domain. We're looking at event-related potentials, P3A and P3B, for a delayed speed and or a reduced power, keeping in mind that these tend to be linearly correlated. So somebody that has severe depression is going to have, and we anticipate they would have a more delayed latency than somebody that just has mild depression. And finally, resting state head maps. We're looking for low power in frontal alpha frequencies. So that blue blob at the front of the brain, in our alpha band 8 to 12, but really honing in on kind of 8, 9, 10 hertz. We did have a question come in about if brain maps are normalized for age. There's actually not a huge difference as we age after we get out of childhood for what the norm should be. So there are databases that can norm for age, but for this purpose, it's not necessary to do that. So we've got our standardized database, and somebody that is 90 years old should, in theory, be having a similar pattern in terms of the head maps as somebody that's 40 years old. Now, there are several biomarkers we report on that are very age dependent. An example of that is peak alpha frequency and theta beta ratio. And so those normal ranges are definitely normed for age, and we keep in mind age when we kind of make conclusions based off of those. But for our resting state head maps, it's really, we want to see a patient within that normative range regardless of age. It shouldn't be changing much, and if it is changing, it's because of pathology. So diving into some case studies, this is a great example of depression that's kind of a mild depression, right? It's nothing super severe, and we'll talk about why. So this is a 39-year-old female patient, and in her self-reported symptoms, she's experiencing a lot of difficulty, right? She's reporting problems with executive and attention function, affect, word fluency, sensory, and motor skills. So basically everything across the board is a concern for her, and it demonstrates that if you were just using questionnaires, it might be difficult to hone in on what has actually gone wrong here. When we look at her ERPs, we see that latency is just moderately delayed, right? We're looking at 452 versus 450. That's essentially the same, as well as 484 versus 450. That's very close, only very slightly delayed. The most noticeable thing here is a flag for her P3B amplitude. She's got a 9.3, which for any other patient would be okay. But for this patient, her P3A amplitude is all the way up at 19.5. And we'd like to see P3B amplitude in that same region, that same level, at least double digits. So for this patient, she was flagged for a low amplitude for her P300B, just because for her brain, we think this is a bit of a reduced neural horsepower for her working memory processes. And when we hop over to our neuroimaging section, we see a little bit of that light blue at the front of the head for that 8, 9, and 10 region, that frequency band. So, and then finally, the heart rate variability, we do see a reduced SCNN, a reduced total power, and sympathetic dominance. So overall for this patient, a relatively mild case of depression. Certainly manifesting to the point where the patient feels a lot of concern and very regular concern in day-to-day functioning, but pathologically not a severe case, which is good. It's something that we should be able to treat relatively easily and correct. Looking at this depression case, we have something that's a little bit more severe. So this is an 81-year-old patient. She is reporting 100% in every single self-reported symptom domain. So this is a patient that probably is not being totally honest on what she's experiencing, which again is a challenge of relying on self-reported symptoms. When we look down at her ERPs, P300A and P300B are both indiscernible. So in this case, it's because there's just not enough amplitude for a peak to be present. It's just all noise, so it's indiscernible. There's just no neural horsepower getting up and gearing to go. When we look at neuroimaging, there's blue in the front part of the head. It slipped a little bit into theta, is still affecting alpha. So this is a patient that I would anticipate is not only experiencing depression symptoms, but might also be experiencing a lack of reparative sleep. So problems with, maybe problems with insomnia or sleep apnea that we would want to investigate as well, but certainly depression. And when we pop over to our heart rate variability, again, we're seeing a reduced SCNN, a reduced total power, and that sympathetic dominance. Again, looking at a depression case, you'll see the same pattern recurring over and over. We've got now a 66-year-old female. She has some delayed latencies for P3A and P3B. Fortunately, her neural horsepower is healthy for that amplitude, but her brain is definitely slow to react to stimuli. We see that super clear pattern of deep blue at the front of the brain for that 8, 9 frequency band. And for her heart rate variability, again, a reduced SCNN and total power with sympathetic dominance. Now, this case actually has a follow-up to it. So this is a baseline assessment of somebody that came into an office with a couple different concerns, really recognizing they do have affect concerns, but also with word fluency and motor problems as well. When we look at their ERPs, P3A has a very slowed latency, and then P3B again has that reduced amplitude, not because it's below our absolute cutoff, which is 6 microvolts, but because it's down at 7.7 compared to the P3A amplitude, which is all the way up at 22. So for this patient, we want to see that P3B at a much higher number because that's what's normal for him. And here he has a reduced amplitude and reduced horsepower for P3B compared to where he should be. When we pop over to the neuroimaging section, we see a lot of blue. So sometimes when we see a lot of blue like this, it can indicate kind of a mitochondrial deficiency or some reason that the brain is not receiving the power that it needs to in order to basically do all of the types of cognitive processing that we do. But it is very pronounced kind of at the front of the head for our mood and affect region. And when we look at the heart rate variability, we've got reduced SDNN, reduced total power. Interestingly, this time we see parasympathetic dominance, which means this patient is really stuck in that rest digest mode. And overall, the patient has been complaining the most about affect changes within the last year and experiencing short-term memory problems that have gone kind of hand in hand with that. So the physician made a diagnosis of major depressive disorder, put the patient on an antidepressant. The patient came in 2 months later. Usually that 8-week checkup is where we like to see if an antidepressant is working well or not. And in this case, the patient showed a huge improvement. From baseline, where we see a ton of deep blue, the 2-month follow-up shows such a strong resolution. Only light blue now, mostly green. Symptoms also rebounded very well from this. The patient was no longer experiencing mood and affect problems. Short-term memory had rebounded to what it felt like was normal for him. Notably, heart rate variability did not. So we still see a reduction in SCNN and a reduction in total power and that sympathetic dominance. So sometimes training heart rate variability is something that we have to do directly. Things like biofeedback can be helpful for that. I personally like a tool called HeartMath. And our company is not associated with them at all, but it's just a really great tool that a patient can take home with them and practice biofeedback specifically for heart rate variability on a daily basis, and works very well for kind of retraining heart rate variability to get into that balance zone and can kind of help with symptom resolution as well. Okay, so in terms of questions, we have had a couple that have come in, so let me see if I can pop that out. Okay, so talking about low amplitude in ERPs, meaning poor neural connectivity in localized or neurological pathways. So it's not in any type of localized region per se. We do look at ERPs in different head regions. So P300A is really at the top of the head. P300B is going to be more at the back of the head in the parietal lobe. So it is localized to some extent, but really it's kind of globally looking at how the brain processes stimuli on an overall basis. So low amplitude in ERPs isn't going to be related to any particular neurological pathway. It's just kind of a global understanding of the way we report it here of how quickly the brain is processing information. So great question. And that answer can change based off of the type of literature that you're reading and the specific methods that they use to measure ERPs. So depending on where you're measuring ERPs in the head, that answer changes. but for us, it's not an ERP that's localized activity or any particular pathway. It's much more global. And all right, I think that covers all of our questions today. Hopefully I got to all of them as they were coming in. Thanks so much for being engaged throughout this presentation. Always wonderful to interface with you all. Certainly let me know if you're working through any patient cases that are really challenging. I'm here to kind of walk through those with you, help lend some additional insight. If you're interested in more of our Lunch and Learn webinars, we've got them all available to you. There's a link within your PDF at the bottom of this slide that you can access that Lunch and Learn kind of clinical education page, or you can just shoot me an email and I can give you that link as well. Thank you so much for attending. I hope you learned a lot about depression biomarkers and you are capable of kind of recognizing this depression pattern next time you get an Evox report. Thank you for joining. Take care, everyone.